Thank you, Mr. Chair and members of the committee. My name is James Geluso, and I'm here with Lori Reitman-Garretson to present our audit examining Washington's concurrent Medicaid enrollments. Before we begin, I would like to thank the Healthcare Authority and the Department of Social and Health Services for their cooperation and assistance throughout this audit. We would also like to thank the Office of Inspector General at the U.S. Department of Health and Human Services, the auditors at the Oregon Division of Audits, and the various Washington agencies that provided us with data, the Office of Superintendent of Public Instruction, the Department of Licensing, and the Employment Security Department. As you probably know, Medicaid is the single largest program in Washington's budget. It provides health care for a quarter of residents. 84% of Washington's Medicaid clients receive their care through managed care organizations. When someone on Medicaid moves out of state, they are required to notify the agency responsible for their Medicaid. However, sometimes that doesn't happen. If a person doesn't cancel their Medicaid when they leave and they sign up for Medicaid in their new state, they can end up enrolled in 2 states at once. The result is that 2 states are paying MCOs, but the client only benefits once. At a high level, what we found is that Washington paid $8.6 million a year for unnecessary premiums. That was for clients residing in just 7 states reviewed. Even more was paid in unnecessary premiums for clients in the remaining 42 states. Medicaid is a nationwide program, and it needs nationwide solutions. But we found that there are steps Washington can take to improve its existing processes to reduce these unnecessary premium payments. The impetus for this audit actually came from the federal government. Within the Federal Department of Health and Human Services, the Office of Inspector General has been working on the issue of concurrent enrollment, and it has access to data no single state has. The OIG shared data about Washington's concurrent enrollees with us, allowing us to examine the scale of the problem and the root causes in a way that would otherwise have not been possible. This data shows the premiums Washington spent whenever someone was also enrolled in another state. Because some overlap is expected whenever someone moves, the data includes only people who were concurrently enrolled for 3 months or more. We were also able to team up with auditors in other states, including our neighbors in Oregon. Our audit asked 2 questions. First, to what extent did Washington pay premiums to managed care organizations for enrollees concurrently enrolled in another state's Medicaid program? And second, what additional steps could the Healthcare Authority and the Department of Social and Health Services take to ensure managed care organizations are not paid for enrollees who no longer live in Washington?
Let me ask really quick, just if we're out the 8.6, is the federal government out at a floor? Because they're matching it, the lowest match is 50%, right? So they're out a minimum of 8.6, but theoretically they could pay out even more than that. Is that?
So that 8.6 is state and federal money.
Oh, that's both state and federal money.
Same.
Okay, I gotcha, sorry.
Let's take a look at the scale of the problem. In the 4-year period we examined, 131,000 different people were concurrently enrolled in Medicaid in Washington and another state for at least 3 months. 5% of them were actually enrolled in 3 or more states. In this map, you see the states with the highest number of concurrent enrollees in hot pink and the fewest in white. The exception is Oregon, which has the second most after California. Oregon is highlighted in blue because we pulled them out for special analysis, as I'll explain in a few slides. 3 of the 4 years in our time period were during the public health emergency caused by the COVID-19 pandemic. When the emergency was declared in March 2020, the federal government changed its guidance and encouraged states to keep clients enrolled unless they were absolutely sure they were out of state or had another good reason to remove them. And the federal government offered money to states who followed this new guidance. As a result, the cost of concurrent enrollment in Washington nearly quadrupled from 2019 to 2022. As you can see, in 2022, the last year of the public health emergency, states spent $135 million on unneeded premiums for clients concurrently enrolled in Washington Medicaid. That means either Washington was paying for someone enrolled in Washington but residing somewhere else, or another state was paying premiums for someone residing in Washington. So 135 million on good premiums plus 135 million on unnecessary premiums. That was just for 2022. Over all 4 years, it totaled $300 million. To take a closer look at what was causing concurrent enrollments, we picked the 7 states with the biggest share of enrollments. Together, they total 60% of Washington's concurrent enrollments. We found that even despite federal and state efforts to identify and prevent concurrent enrollments, just for the enrollees in the 7 states, and only counting people who were concurrently enrolled for 6 months or longer, Washington paid $8.6 million a year in premiums for people who were residing in other states.
So did we pay that, or is that the combo of us and the feds?
So
Yes.
those are amounts that Washington paid with state and federal funds.
Okay, got it. Okay.
Yeah.
We then split the 7 states into 2 groups, Oregon and the 6 other states. The 6 states make up 45% of the concurrent enrollments. We drew a sample of 104 people from these 6. And then we made a separate sample for Oregon, which has 15% of concurrent enrollees. We treated Oregon differently because Oregon presented a unique opportunity for us. Not only does Oregon share a large metro area with Washington, but Oregon is unusual in that it handles SSI Medicaid differently than Washington and most other states. And while many states were involved in this partnership, Oregon auditors worked directly with us. At the end, the Office of the Washington State Auditor and the Oregon Division of Audits released our reports on the same day. We used several sources to look at each individual in our sample and found that 4 in 10 of the people in our 6-state sample, in fact, lived outside Washington, while Washington and another state were paying for Medicaid premiums. We looked at records in DSHS's systems, as well as records from the Department of Licensing, Department of Employment Security, school enrollment records provided by the Office of Superintendent of Public Instruction, and even records provided by other states. It's important to note here that we had access to records that DSHS and HCA didn't have, and that we were looking at records years after the fact, not trying to make determinations in real time. So the work we did is not something we can expect from staff at these agencies.
I'm trying to, I think maybe my brain's not working correctly, but obviously Medicaid's like a $10 billion program. Like when you say 4 in 10, like, but that ends up being $8.6 million, like something like what percentage is it of people we think are dual enrolled? Because I'm trying to track, because that looks like a 40% number, but I thought the dual enrolled number is much smaller. Like, what am I not doing right in my head?
Okay, so just to walk through this, so what we did is we had the data set with all of the people who are concurrently enrolled in Washington and another state for 4 years. So we have that big data set.
That's the data, okay.
And then what we did is we pulled a sample from that big data set and we dove deep with that sample. So here we have a sample where we're looking at all of the different records, but we only did that for 104 people and then for 100 people that were concurrently enrolled with Oregon. And so here we're talking about the results just for that sample.
Okay.
And then James is going to share the results for the Oregon sample.
Okay.
Yeah.
When it comes to figuring out which state someone lives in, HCA and their counterparts in Oregon have an especially tough job. Especially around the Vancouver area, many clients may receive medical care in both Washington and Oregon. Washington residents may move temporarily to Oregon for work, school, or family reasons, which does not disqualify them from Washington residency. And many of those concurrent enrollees were homeless and crossed the border frequently. When we looked at Oregon, we were able to partner with auditors at the Oregon Division of Audits. They were able to give us more information about their concurrent enrollees than we had from any other state. Our deep look at the individuals found that half the people in our sample lived in Oregon all or part of the time that both Washington and Oregon were making payments for them. When we looked at the individual stories of clients, we saw that homelessness and other challenging situations were contributing factors in many concurrent enrollments. We found that adults in our sample were more than twice as likely to be homeless as Washington's general adult managed care population. Other clients had unstable housing, were fleeing domestic violence, or struggled with substance abuse disorders or psychiatric illnesses. From here, I'll turn it over to Lori Ryman-Garrettson to talk about Washington systems and how they can improve.
Thank you, James. So as James mentioned, clients are required to report address changes, but many don't. Because of this, HCA and DSHS have processes in place to detect unreported moves that might render someone ineligible for Washington's programs. Both agencies participated in a national matching program called PARIS. With PARIS, the Federal Health and Human Services received client rosters from states across the nation, compared the rosters, and then provided states with quarterly reports of clients receiving benefits from multiple states. Both HCA and DSHS used these quarterly reports to identify clients who had moved out of state. Both agencies also monitored returned mail, and DSHS monitored out-of-state EBT usage associated with food benefits. In addition, when DSHS closes coverage for a client that has clearly left Washington, its system automatically notifies HCA. We reviewed these notifications and found they were working as intended and that HCA staff were indeed responding to them in a timely manner. However, in our case file review, we identified numerous cases where DSHS learned that someone was out of state, but the system was not programmed to send a notification in that circumstance. For example, in one case, another state called DSHS about a client that was applying for benefits there. That client was not enrolled in food benefits with DSHS, so the DSHS worker told the worker from the other state that the client would have to contact HCA to cancel their Medicaid. The client did not do so, and Medicaid remained open in Washington for 10 more months. There was no procedure for the DSHS caseworker to follow to contact HCA in this case, and the system wasn't programmed to notify or alert HCA. HCA managers believe additional information could be useful, and had they known about the circumstances in this example, they could have initiated HCA's independent residency verification process.
So can you explain again why sometimes it works, but in that one specific example, you decided it didn't work?
It all goes down to so it's an automated notification, and it is with the closure codes that were used. And it's not that it was coded incorrectly. It was coded correctly for that situation, but those codes didn't trigger the notification. So certain closure codes did trigger the notifications and others didn't. So, but with that, there was additional information that the caseworker had.
Right.
Yeah. So, reducing unnecessary premium payments for residents in other states falls under wider program integrity efforts, and HCA's contracts with the MCOs outline numerous program integrity requirements. These contracts are subject to regular updates. We identified 2 possible contract amendments that could help HCA avoid unnecessary premiums and even recover some. First, HCA could require 4 of the MCOs to take advantage of the fact that they are part of larger national corporations that provide Medicaid in many states. These MCOs could perform their own matches, checking their own client rosters in their various states to see if someone shows up more than once. This is a low-cost requirement that could spot some concurrent enrollments much faster than the PARIS process. Second, the contract could be amended to allow HCA to recover or recoup premiums that were paid for clients who were later found to be ineligible because they were residing outside of Washington. Currently, the contract allows recoupment under several circumstances, including death or incarceration, but residing out of state is not one of them. We consulted with managers from the 5 MCOs, and they told us they did not object to such a provision so long as it only applied to clients where they had not made any payments to providers for their care.
Say that last qualification again. It would only qualify to clients who had not made.
So they don't object to having some sort of a recoupment clause or an ability to recover, so long as it only applies to situations where they hadn't made payments to their provider network for that client's care. And that wouldn't be the case if someone has clearly left the state.
Okay.
Yeah, they wouldn't be paying anything to their providers.
Got it.
Yes. For many aspects of the concurrent enrollment problem, a real solution can only be achieved at the federal level. DSHS and HCA managers and other state auditors around the country who've examined this issue all said federal action is needed. Participation in the existing Paris process is inconsistent, and even when states participate fully, there are variances in their data, which limits how useful it can be. Furthermore, in May 2024, the Paris system ceased operations due to a lapsed data sharing agreement with the Department of Defense, which did the actual data matches. As of August 2024, the Paris program had begun working with the U.S. Department of Treasury to match enrollment records for states' public benefit programs. However, officials at the Treasury Department said it would not start running the matches until at least 40 states had signed on to participate. So the timeline for when this would start was uncertain. Like most states, Washington has an agreement with the federal government which allows the Social Security Administration to determine who is eligible for Medicaid based on their enrollment in Social Security Administration programs. The problem is that sometimes clients leave Washington, but the client does not or cannot change their address with Social Security. They enroll in another state's Medicaid program, but Social Security's system tells DSHS's system to enroll the client in Medicaid again. In addition to creating a concurrent enrollment, this can cause problems accessing coverage and care for clients in their new home states because they're still enrolled in Washington's Medicaid program. In response to this issue, DSHS has developed a mechanism to block automated re-enrollments when clients are clearly residents of other states. However, some managers at HCA and DSHS were concerned that this might violate Washington's agreement with the Social Security Administration. As I've mentioned, solutions are needed at the federal level, and we've shared our audit results with the federal HHS OIG so they can continue to work with CMS on this issue. The HHS OIG is sharing this audit report with CMS. With that, we have some recommendations for Washington state agencies. Specifically, we recommend that HCA and DSHS collaborate to ensure that DSHS notifies HCA when clients enrolled in DSHS programs who are also enrolled in income-based or MAGI Medicaid move out of state. We also recommend that HCA request needed clarity from federal partner agencies on handling unwanted auto re-enrollments caused by inaccurate information from the Social Security Administration. And finally, we recommend that HCA amend its contracts and processes to require MCOs to check for people enrolled in their programs in more than one state, and to allow HCA to recoup premiums for enrollees who are later found to be resident in another state. That concludes our presentation, and we would love to address any questions you might have.
Okay, thank you very much. Is there questions for the audit's office where I think we have folks from HCA, DSHS here. Do you guys want to come up? I think you guys could be off the hook. Thank you.
Yes. Good afternoon, Chair Mullet and members of the committee. For the record, my name is Terry Redmond, and I have the privilege of serving as the Assistant Secretary of Economic Services within the Department of Social and Health Services. DSHS's Economic Services Administration is the national leader in providing poverty reduction services to over 1.7 million Washingtonians. We help our clients meet their basic needs and achieve economic independence through cash grants, food, and medical assistance, employment-focused services, refugee and immigrant assistance, disability determinations, and child support collection. While the Washington State Health Care Authority, HCA, is the official Medicaid agency for Washington State, coordination between our agencies, as outlined in the auditor's report, is critical and something our administration is committed to fulfilling. Much of the work is to make that coordination happen, which occurs in the Community Services Division. Joining me today to share some additional context is the Interim Director, Bryce Montgomery. Thank you for the opportunity to address the committee today. Bryce.
Thank you. Should I refer to HCA first? Would you like to go first, or shall I?
Why don't you go first, Bryce, and then we'll go to Maggie after.
All right. Good afternoon, Chair Bullitt, Vice Chair Orcutt, and members of the committee. Thank you for the opportunity to meet with you all today. For the record, I'm Bryce Montgomery, serving as the Director of the Community Services Division at the Economic Services Administration of DSHS. Work of the division includes medical assistance service delivery for aged, blind, or disabled people with low incomes. Thank you for the opportunity to represent the agency and answer any questions you may have. I'd like to highlight a few points before I take questions. Under federal regulations, the state must provide Medicaid to aged, blind, and disabled individuals or couples who are receiving or are deemed to be receiving Supplemental Security Income, or SSI. The SSI-related Medicaid caseload is only about 5% of our state's managed care clients. Most SSI-related Medicaid cases are automatically enrolled in our eligibility system based on data received from the Social Security Administration. While DSHS could turn off the auto-enrollment feature when an SSI client moves out of state, both DSHS and HCA believe that doing so would put us in non-compliance with federal regulations. Because the state must provide Medicaid to aged, blind, and disabled individuals or couples who are receiving or deemed to be receiving SSI, Washington remains bound by the federal requirement to provide Medicaid based on Social Security Administration records, even when an SSI recipient moves out of state but does not update their state of residency with Social Security. DSHS sends automatic alerts to HCA for active MAGI Medicaid cases when a client's mailing or residential address is updated to an address outside of Washington, and when a client's food or cash assistance is terminated due to not meeting Washington state residency. Under federal regulations, state agencies must provide Medicaid to eligible residents of the state unless a person has an established residency enrolled in Medicaid in another state. The Medicaid agency may not deny or terminate a resident's Medicaid eligibility because of the person's temporary absence from the state if the person intends to return. The state must also confirm that the state has permanently moved out of state before disenrolling them from Medicaid. And as the auditor's office mentioned, the state uses a public assistance reporting information system, or PARIS, and residency information from other assistance programs to monitor out-of-state residency changes. However, if clients are not forthcoming regarding their change of residency, the process to verify their current state of residency and Medicaid enrollment can be challenging. DSHS strategic priorities aim to promote efficient, effective, and accountable government, as well as operational excellence, and we are committed to applying these priorities as we address the SAO recommendations through our ongoing partnership with HCA. I'm happy to take any questions from the committee and turn over to our HCA representatives as well.
So before we go to Maggie, right, so you're saying the federal government, if somebody was on the ABD program because they qualify for SSI and they move out of state, and then we know they've moved out of state, so we disenroll them from Medicaid, we'd be violating the federal rules because they haven't disenrolled themselves or acknowledged their move? Or can you explain that nuance one more time, I guess?
Yes, that's what we think, that this would be a violation of the Social Security rules, the federal regulations, because they are required to be provide services based on their Social Security address.
Okay. Even if that address is faulty, I guess it doesn't matter. That's what okay. Maggie, why don't you go ahead?
Good afternoon, Chair Mullet, Vice Chair Orcutt, and members of the committee. Thank you for the opportunity to meet with you all today. For the record, I'm Maggie Clay, Section Manager of Eligibility Policy, Innovation, and Community Support at the Healthcare Authority. Our unit works closely with the Centers of Medicare and Medicaid Services, CMS, to interpret and implement statewide Medicaid eligibility policies. I'd like to thank the state auditor for bringing attention to concurrent enrollment. It's a complicated issue, and while there are areas for improvement that our state can address, a complete resolution will involve a coordinated effort with CMS and all the Medicaid agencies across the nation. Just a few areas about this audit I'd like to highlight from the agency's perspective. This audit follows up on an OIG audit, that recommended CMS provides Medicaid agencies with data from their national system so states can identify clients concurrently enrolled in Medicaid. States currently lack access to this comprehensive data that would allow us to check for multi-state enrollments. The audit found concurrent enrollees by using information outside the state's regulatory authority. Auditors pulled the audit sample using a state data set not available to states. Additionally, to verify residency, auditors reviewed systems HCA and DSHS do not have access or authority to utilize. These included Department of Licensing, Employment Security Department, as well as working directly with auditors in other states. This audit reviewed the timeframe of the public health emergency. Federal policy was committed to ensuring continuity of coverage during this time and prohibited disenrollment for most reasons. Disenrolling clients for Medicaid is a serious matter, and staff worked diligently to process all available information to ensure ongoing eligibility. Finally, this audit helped us to identify key areas in our own processes where we can make improvements. HCA and DSHS are in the process of evaluating those areas where we can implement changes, are committed to working together to strengthen our processes and stewardship of funds. Thank you.
So I guess Maggie, like in the one recommendation with the managed care organizations like Molina or whoever, like what's preventing us from just putting in our contracts going forward that we can recover if we can prove that somebody moved out of state and they weren't receiving benefits in our state anymore? Would that be a no-brainer change to have our contracts put that language in, or is there a issue that you see with that language?
Yeah, I think the teams are definitely, evaluating the possibility of doing that. I think the concern is, as the auditors highlighted, if there are previous bills, from the client in those months, and how to identify those. So something the agency will be evaluating as we move forward from this audit.
Got it. And Maggie, by the way, you won the award for nicest virtual background of the day. You make me want to leave this room. Okay, is there any other questions for HCA or DSHS? Okay, well, thank you very much. I appreciate everyone's comments. We appreciate your time. And with that, this I-900 meeting is adjourned.